With acute leukemia, leuc refers to white blood cells, and emia refers to the blood. So, in acute leukemia, there's uncontrolled proliferation of partially developed white blood cells, also called blast cells, which build up in the blood over a short period of time. Although leukemia specifically means cancer of the white blood cells, it can also be used to refer to cancer of any of the blood cells, including red blood cells and platelets. Acute leukemia can be broadly classified into acute myeloid leukemia, or AML, and acute lymphoblastic leukemia, or ALL. AML is more common in old age, whereas ALL is more common in children. In both cases, accumulation of blast cells interferes with the development and function of healthy white blood cells, platelets, and red blood cells. Every blood cell starts its life in the bone marrow as a hematopoietic stem cell. Hematopoietic stem cells are multipotent, meaning they can give rise to both myeloblasts, which are precursors of myeloid blood cells, and lymphoblasts, which are precursors of lymphoid blood cells. These lymphoblasts can be pre-B cells, which develop into B lymphocytes, or pre-T cells, which, you guessed it, develop into T lymphocytes. If a hematopoietic stem cell develops into a myeloid cell, it'll mature into an erythrocyte, or a red blood cell, a thrombocyte, or a platelet, or a leukocyte, which is a white blood cell, like a monocyte or a granulocyte. Granulocytes are cells with tiny granules inside of them. They could be neutrophils, basophils, or eosinophils. If a hematopoietic stem cell develops into a lymphoid cell, on the other hand, it'll mature into some other kind of leukocyte, a T cell, B cell, or natural killer cell, which are referred to as lymphocytes. Once the various blood cells form, they leave the bone marrow and travel around the blood, or settle down in tissues and organs like the lymph nodes or the spleen. Acute leukemia is caused by a mutation in the precursor blood cells in the bone marrow. In the case of ALL, it's usually due to a chromosomal translocation or an abnormal chromosome number. Common chromosomal translocations include translocation of chromosome 12 and 21 and translocation of chromosomes 9 and 22, also called the Philadelphia chromosome. These result in production of abnormal intracellular proteins, which affect the cell's function and cell division. ALL can further be classified into T-cell ALL, where there's proliferation of T-cell precursors, and B-cell ALL, where there's proliferation of B-cell precursors. AML is caused by a wide variety of abnormalities, like chromosomal translocations, which are used to subclassify AML into a few different types. AML can be classified based on the morphology of the myeloblast into AML without maturation, AML with minimal maturation, AML with maturation, acute promyelocytic leukemia, acute myelomonocytic leukemia, acute monocytic leukemia, acute erythroid leukemia, and acute megakaryoblast leukemia. Of these, acute promyelocytic leukemia is an important subtype. It's characterized by translocation of chromosomes 15 and 17, which disrupts the retinoic acid receptor alpha gene, which is required for normal cell division. Now, there are certain conditions that can actually lead to AML, like myelodysplastic syndrome, which is characterized by defective maturation of myeloid cells and buildup of blasts in the bone marrow. Usually, the buildup is initially less than 20% blasts, but that's enough to cause a decrease in the function of red blood cells, granulocytes, and platelets. As the disease progresses, the blast percentage may go over 20%, resulting in AML with a background of myelodysplasia. Another condition often associated with both AML and ALL is Down syndrome, which is caused by an extra 21st chromosome, so that there's a trisomy 21. Finally, there are also some other risk factors for acute leukemia, like exposure to radiation and alkylating chemotherapy, which may have been used as treatment for some other type of cancer. Alright, now regardless of the type of mutation, acute leukemias share a similar pathogenesis. The mutation does two things. First, it causes the precursor blood cells to lose their ability to differentiate into mature blood cells. This means that they're stuck in the blast stage of development, and the blast cells don't function effectively. Second, it makes the blast cells divide uncontrollably and, in this process, take up a lot of space and nutrition in the bone marrow. This means that the other normal blood cells growing in the bone marrow get crowded out, and it's tough for them to survive with the extra competition for nutrients. This causes cytopenias, or a reduction in the number of healthy blood cells, like anemia, which is a reduction of healthy red blood cells, thrombocytopenia, a reduction of healthy platelets, and leukopenia, or a reduction of healthy leukocytes. As the number of these blast cells in the bone marrow keeps increasing, they spill out into the blood. Now, some of these little guys, especially lymphoblasts, settle down in organs and tissues across the body, like in the liver and spleen. Sometimes pre-T cells in T-cell ALL migrate to the thymus or lymph nodes like normal T cells do, and they settle down there, causing these structures to enlarge. Also, in acute promyelocytic leukemia, the promyelocytes activate the clotting process, and this, combined with the already decreased platelets, results in disseminated intravascular coagulation. Symptoms of both AML and ALL include fatigue because of the anemia, easier bleeding because of the thrombocytopenia, and more frequent infections because of the leukopenia. Pain and tenderness in the bones can occur when there's increased cell production, which causes the bone marrow to expand. Hepatosplenomegaly often causes a feeling of abdominal fullness, while the lymphadenopathy often causes mild but localized pain in the lymph nodes. However, hepatosplenomegaly and lymphadenopathy are both seen more prominently in ALL rather than AML. In addition, monocytic variety of AML causes swelling of gums because of monocytic infiltration. Thymus enlargement in TALL may present as a mass or growth in the mediastinum. The diagnosis of AML and ALL usually starts with a peripheral blood smear, which shows a lot of blast cells, myeloblasts in the case of AML, and lymphoblasts in the case of ALL. This is usually followed up by a bone marrow biopsy, which also shows an increase in blast cells. In acute leukemia, the percentage of blast cells in the bone marrow goes up from their normal value of 1 to 2% to greater than 20%. An important step in the diagnosis is to differentiate AML from ALL. This can be done by identifying the blast cells as either myeloblast or lymphoblasts in a specially stained smear. Myeloblasts are usually large cells with nuclei containing fine chromatin and prominent nucleoli. A classic feature of myeloblasts in AML, especially acute promyelocytic leukemia, is the presence of Auer rods in the cytoplasm, which are crystallized aggregates of the myeloperoxidase enzyme. On the other hand, lymphoblasts are relatively smaller cells with coarse chromatin, which are clumped together and have small nucleoli. Lymphoblasts have very little cytoplasm, which has glycogen granules. In addition, immunophenotyping is done to detect certain markers. For example, TDT, which is a DNA polymerase that's present only in the nucleus of the lymphoblast, is therefore a marker for them, and CD10 is a surface marker for pre-B cells. Treatment of acute leukemia is mainly aimed at reducing the number of blast cells to allow the other blood cells to develop normally. Treatment of AML and ALL is based on the type and stage of the cancer, but in general involves chemotherapy, biological therapy, stem cell transplants, or bone marrow transplants. Acute promyelocytic leukemia can be treated with all-trans retinoic acid, or ATRA, which is a derivative of vitamin A. ATRA binds to the disrupted retinoic acid receptor and causes the blasts to mature into neutrophils, which, like all things, eventually go on to die, thereby cleaning out a lot of the blasts from the blood. Alright, as a quick recap. Acute leukemia is a cancer of the blood cells and is classified into AML and ALL. AML can be further subdivided into different types based on cytogenetic abnormalities or blast cell morphology. ALL, on the other hand, is classified into T cell ALL and B cell ALL. Both AML and ALL lead to accumulation of blast cells in the bone marrow, which interferes with the development and function of healthy white blood cells, platelets, and red blood cells. Major symptoms include fatigue, easy bleeding, fever, bone pain, hepatosplenomegaly, gum swelling in monocytic type, and mediastinal mass in TALL.
With chronic leukemia, leuc refers to white blood cells, and emia refers to the blood. So in chronic leukemia, there are lots of partially developed white blood cells in the blood over a long period of time. These partially developed white blood cells interfere with the development and function of healthy white blood cells, platelets, and red blood cells. Now, every blood cell starts its life in the bone marrow as a hematopoietic stem cell. Hematopoietic stem cells are multipotent, meaning that they can give rise to both myeloid or lymphoid blood cells. If a hematopoietic stem cell develops into a myeloid cell, it'll mature into an erythrocyte, or a red blood cell, a thrombocyte, or a platelet, or a leukocyte, or a white blood cell, like a monocyte or a granulocyte. Granulocytes are cells with tiny granules inside them, and they include neutrophils, basophils, and eosinophils. If a hematopoietic stem cell develops into a lymphoid cell, on the other hand, it'll mature into some other kind of leukocyte, like a T cell, a B cell, or a natural killer cell, which are referred to as lymphocytes. Once the various blood cells form, they leave the bone marrow and travel around in the blood or settle down in tissues and organs like the lymph nodes and spleen. A chromosomal abnormality in hematopoietic stem cells that are destined to become leukocytes is the most common cause of chronic leukemia. Some examples of abnormalities include a chromosomal deletion, where a part of a chromosome is missing, a trisomy, where there's one extra chromosome, and a translocation, where two chromosomes break and swap parts with each other. Now, there are two types of chronic leukemia. The first is chronic myeloid leukemia, or CML, which is caused by a particular chromosomal translocation that affects granulocytes. The second is chronic lymphocytic leukemia, or CLL, which is caused by a variety of chromosomal mutations that affect lymphocytes, in particular B cells. Both CML and CLL cause cells to mature only partially, and that's a key distinction from acute leukemias, where the cells don't mature at all. As a result, these abnormal, premature leukocytes don't work effectively, which weakens the immune system. In addition, the chromosomal changes alter the cell's normal cell cycle. As a result, in CML, the cells start to divide way too quickly, and in CLL, the cells don't die when they should. And in both situations, we're left with way too many of these premature cells. So over time, premature leukocytes accumulate in the bone marrow, until eventually they spill out into the blood. Now, some of these guys settle down in organs and tissues across the body, but others keep circulating in the blood. With a bunch of extra cells in the blood, all the healthy cells get crowded out, and it's tough for them to survive with the extra competition for nutrients. This causes cytopenias, or a reduction in the number of healthy blood cells, like anemia, which is a reduction of healthy red blood cells, thrombocytopenia, a reduction of healthy platelets, and leukopenia, or a reduction in healthy leukocytes. In chronic myeloid leukemia, the most common cause is a chromosome translocation, which results in a Philadelphia chromosome. And that's where a portion of chromosome 9's long arm switches with a portion of chromosome 22's long arm. And we write that as T922. T because it's a translocation, and 9 and 22 because those are the chromosomes that switch genetic information. This results in a modified chromosome 9 and a modified chromosome 22. And it's the chromosome 22 that's called the Philadelphia chromosome. So, in the Philadelphia chromosome, a chromosome 22 gene, which is the BCR gene, ends up sitting right next to a chromosome 9 gene, the ABL gene. When they're combined, it forms a fusion gene called BCR-ABL, which codes for a protein also called BCR-ABL, which is a constitutively active tyrosine kinase, meaning that BCR-ABL is like an on-off switch stuck in the on position. Since BCR-ABL helps control various cellular functions like cell division, having it always on forces myeloid cells to keep dividing quicker than they should, which causes a buildup of premature leukocytes in the bone marrow that eventually spill into the blood. The premature leukocytes then move to the liver and spleen, causing swelling of those organs or hepatosplenomegaly. And because these CML cells divide quicker than they should, there's a high chance that further genetic mutations can happen. And if that happens, CML might progress and accelerate into a more serious acute leukemia, which is called a blast crisis, because the totally immature cells of acute leukemias are referred to as blasts. A lot of cases of these blast crises include the formation of a trisomia on chromosome number 8, or the doubling of the Philadelphia chromosome. In chronic lymphocytic leukemia, the most likely cause is also a mutation in the cell's chromosomes. We just don't know which particular mutation, or mutations. Whatever the case, the result is that B cells start to interfere with the pathways of B cell receptors, which should only be signaled during infection to activate a few specific tyrosine kinases. Interference with Bruton's tyrosine kinase, for example, is probably what stops CLL cells from maturing fully. And it's similar interference with other tyrosine kinases that allows them to die slower than they divide, which is why they build up. These premature cells always express particular proteins on their surfaces, including CD5, CD19, and CD23. The CD part stands for cluster of differentiation, because these are common surface proteins which can be used to differentiate between the lymphocytes. And despite CLL cells being B lymphocytes, they express the CD5 protein, which is a lot more common in T lymphocytes. Anyway, these premature leukocytes build up in the bone marrow and eventually spill into the blood, like in CML. Some of these cells then move to the lymphatic system, and although this does include the spleen, the lymph nodes are typically prioritized. This causes swelling of the lymph nodes, or lymphadenopathy. Then eventually, B cells in these nodes will accumulate into distinct masses, or lymphomas, which is why mature CLL is sometimes called small lymphocytic lymphoma. Further progression might take the form of a Richter transformation, where those small, pretty harmless lymphomas collect into sizable masses that damage the body. And because B cells normally work in the immune system, the reduced or adverse functioning of CLL cells might result in autoimmune hemolytic anemia, where the cells attack the body's own red blood cells and kill them off. Or hypogammaglobulinemia, where the cells don't produce enough gamma globulins. Symptoms of both CML and CLL include fatigue because of the anemia, easier bleeding because of the thrombocytopenia, and more frequent infection because of the leukopenia. In CML, the hepatosplenomegaly often causes a feeling of abdominal fullness, while the lymphadenopathy of CLL often causes mild but localized pain in the lymph nodes. The diagnosis of CML and CLL usually starts with a blood smear, which shows a lot of premature leukocytes. In CML, there are an increased number of granulocytes and monocytes, and in CLL, there are often smudge cells on the blood smear, which are immature B cells that have broken during the smear. For a conclusive diagnosis, genetic testing can be done to look for the Philadelphia chromosome in CML and to look for chromosomal defects in CLL. Treatment for CML always includes biological therapy, with a tyrosine kinase inhibitor aimed at stopping cell division caused by the BCR-ABL protein. This is less effective for CLL, though, since there's no specific target. Other options for both CML and CLL include chemotherapy, stem cell transplants, or bone marrow transplants. Alright, as a quick recap. Chronic leukemia is a cancer of the leukocytes that includes both chronic myeloid leukemia, or CML, and chronic lymphocytic leukemia, or CLL. In CML, a chromosomal translocation results in a Philadelphia chromosome, which codes for a protein called BCR-ABL. As a result, myeloid leukocytes like granulocytes and monocytes stop maturing and reproduce too quickly. These build up in the liver and spleen and cause hepatosplenomegaly. In CLL, a variety of chromosomal abnormalities interfere with the pathways of B cell receptors. As a result, lymphoid leukocytes like B cells or B lymphocytes stop maturing and die too slowly. These build up mainly in the lymph nodes, causing lymphadenopathy. Both types cause a loss of normal blood cells, resulting in things like anemia, thrombocytopenia, and leukopenia.